presenter دكتورة إيمان مجدي وهتقول لنا presentation about challenges in pediatric breast lesions. اتفضلي.
بسم الله الرحمن الرحيم. We're here to discuss points of pediatric breast lesions, case-based discussion. I'm Eman Magdy, assistant lecturer of radiology diagnosis, Benha University. Breast masses in children and adolescents are uncommon. Knowledge of the clinical presentation and imaging feature of various stages of the normal development and mass-forming lesion in the pediatric breast can guide a tolerated imaging approach and help radiologists make a definite diagnosis. When clinically warranted, ultrasound is the mainstay for imaging the pediatric breast and require careful correlation of sonographic finding with the patient age and history. Benign causes of breast lump in children and adolescents include normal and developmental variant, infection, trauma, and tumors, such as fibroadenoma. Malignant tumors in the pediatric breast are extremely rare and constitute only for 5% of pediatric breast masses. A malignant breast mass in this age group is most often a metastasis rather than a primary breast cancer. We will show some of common cases in the pediatric age group. Case 1. A 4-week-old full-term girl presented with non-painful enlargement of both breast buds without prominence of the nipple areola complex. Ultrasound show stimulated enlarged oval-shaped right breast bud with tubular and rounded connecting cystic channels corresponding to dilated mammary duct. Similar findings were seen on the contralateral breast. Also another picture of bilateral enlargement with the same case with color Doppler. We are dealing with a transient physiological neonatal breast enlargement. During the first week of life, the duct may hypertrophy under the influence of placental hormones, causing transient physiologic neonatal breast enlargement in up to 70% of newborn. It can be unilateral or bilateral, more frequently bilateral. Neonatal breast enlargement is a self-limiting, require no treatment, and often resolve over by 6 months of age. The normal breast bud may continue to demonstrate physiologic fluctuation in size and remain palpable until 1 to 2 years of age and remain quiescent until puberty. Case 2. A 4-week-old female infant presented with painful enlargement and erythema of the left breast. Color Doppler ultrasound show left subaerial breast tissue heterogeneous enlargement of the breast bud with echogenic hyperemia surrounding the mass. We are dealing with a neonatal mastitis, which is commonly affect infant in the first 3 weeks of life, calling it mastitis neonatorum. If left untreated, results in abscess cavity shown as a hypoechoic collection, no vascularity within the collection, posterior acoustic enhancement due to fluid content and the echogenic vascular rim, as seen in this picture. Case 3. 7-year-old female presented with bilateral breast retroaurial masses, more on right side. Ultrasound image show right breast show a heterogeneous hypoechoic star-shaped mass. Left breast show small hyperechoic retroaurial nodule. The right side show regular mass, heterogeneous, and the left show echogenic nodule. We can judge on this image is this normal or this pathology until we know 2 terms. What is CELARC? What is tunnel staging of breast development? What is CELARC? CELARC is the onset of pubertal breast development between 8 and 13 years of age. The onset of breast development before 8 years of age is considered premature or precocious. Idiopathic premature CELARC occur without any other signs of puberty. Precocious puberty as a cause for premature CELARC should be considered if additional signs of sexual maturation are present, and further evaluation is needed to exclude hormonally active adrenal or gonadal neoplasm as a cause. Radiological evaluation for suspected precocious puberty should include bone age assessment, abdominal and pelvic sonography to look for evidence of maturation of the uterus and the ovaries. In addition, ovaries and adrenal gland should be evaluated for estrogen-producing lesion, including functional ovarian cyst, juvenile granulosa cell tumor of the ovary, feminizing adrenal cortical tumor. Okay. What about tunnel staging for breast development? We have a 5 stages of breast development. Stage 1 in photo A, it represents as a subaerial nodule, echogenic. Photo B, stage 2, it represents an echogenic nodule with a central satellite hypoechoic focus. Stage 3 in photo C, we show expanded hyperechoic glandular tissue with central branching and nodular hypoechogenicity. Stunner stage 4 show a continued expansion of the echogenic fibroglandular tissue with increasing subcutaneous fat. Stunner stage 5, breast tissue show more fibroglandular tissue without central hypoechogenicity. So in this case, we are dealing with a premature CLR in a 7-year-old girl with a right side show a Tanner stage 2, a left side show Tanner stage 1. Case 4, 13 years old adolescent boy with enlarging breast. Ultrasound image of the right subareolar breast show a hypoechoic mass with a microlobulated margin. We are dealing with a physiologic dendritic gynecomastia. Ultrasound can help confirm the presence of gynecomastia by demonstrating one of the 3 typical imaging patterns: nodular, or dendritic, or diffuse. Nodular gynecomastia appear as a well-defined hypoechoic mass. Dendritic gynecomastia as a flame-shaped hypoechoic mass with microlobulated margin. Diffuse gynecomastia as a normal fibroglandular tissue similar to that seen in women. Gynecomastia can be also secondary to condition associated with increased estrogen level such as Klinefelter syndrome, testicular feminization, neurofibromatosis type 1, and tumors such as prolactinoma. Drugs also can cause gynecomastia, including exogenous estrogen, anabolic steroid, and marijuana. We should differentiate it from pseudogynecomastia, which is enlargement of the breast owing to general obesity and increased fat deposition, and that may mimic true gynecomastia. Case 5, a 14-year-old girl presented with left hypomastia. Ultrasound show normal right breast show as a large amount of the breast tissue compared to the left one, and normal pectoralis muscle. Left side show diminished breast tissue with absence of the pectoralis muscle compared to the right side. So we are dealing with Abulan syndrome. Abulan syndrome is referred to a congenital unilateral absence of the pectoralis major and pectoralis minor muscle. As shown in this mammography, we have absence of the pectoralis muscle in the right side. Case 6, 17-year-old adolescent girl with an enlarging right breast lump. Ultrasound show 9 cm circumscribed hypoechoic mass. We do ultrasound guided biopsy, was performed owing to the larger size of the mass. We are dealing with a juvenile giant fibroadenoma. It is a rare type of a fibroadenoma that manifests with a rapid growth and large size. Black girls are predominantly affected, and bilateral and multiple masses are found in 10 to 25 of patients. Masses greater than 5 to 10 centimeter in diameter are termed giant fibroadenoma, and most often are the juvenile variant. Sonographic appearance of juvenile fibroadenoma is similar to that atypical fibroadenoma except for a larger size. We should also differentiate it from a phyloid tumor. Phyloid tumors are often indistinguishable from fibroadenoma. However, presence of heterogeneous internal ecotexture, cleft-like anechoic cystic spaces, increased vascularity are suggestive but not pathognomonic of phyloid tumor. Case 7, 15-year-old adolescent girl with a palpable right breast mass. Ultrasound show an ill-defined complex mass containing innumerable cystic spaces. Axial MRI show irregular right breast mass containing T2 hyperintense cystic spaces. We are dealing with juvenile papillomatosis. Juvenile papillomatosis is a rare localized proliferative disorder of multiple papilloma present in peripheral duct. Ultrasound image show an irregular complex hypoechoic mass with internal cystic spaces. The cyst is undilated duct contained within dense fibroglandular tissue that make up papillomatosis and give rise to south sheath appearance. Small echogenic foci representing microcalcification may be present. On MRI, papillomatosis appear as T1 hypointense lobulated mass with avid enhancement and internal T2 hyperintense cystic spaces. Also, it is benign. Papillomatosis is a marker for familial breast cancer, and 5 to 15 of patients will have concurrent breast cancer. Treatment is complete surgical excision with negative margin. Affected patients should be closely monitored owing to an elevated lifetime risk of breast cancer. Case 8, a 17-year-old adolescent girl who presented with an enlarging right breast lump. Ultrasound showed an irregular hypoechoic mass with indistinct margin. We are dealing with a pseudo-angiomatous stromal hyperplasia, BASH disease. BASH is a hormonally responsive blind proliferative of stromal myofibroblast, which contains slit-like spaces mimicking vascular channel. While BESH is usually discovered incidentally at pathologic analysis, it can manifest as a palpable painless firm rubbery lump. BESH demonstrates rapid growth in adolescent. Ultrasound appearance is variable, but it can appear as heterogeneous or hypoechoic oval mass with circumscribed margin. Case 9, 6 months old female present with left breast mass that appear at birth and appear after birth and enlarged inside. Photo A, present with left breast mass, soft tissue with no overlying skin discoloration. In B and C, ultrasound show, left axilla show a heterogeneous soft tissue mass with marked hypervascularity in color Doppler. C and D, axial intravenous contrast enhanced MRI show soft tissue mass is avidly enhancing. After 2 years of follow-up, we do MRI, the mass show significant interval decrease in size consistent with the spontaneous involution. We are dealing with infantile hemangioma, which have a predictable life cycle and traditionally absent at birth, with rapid growth in the first few weeks of life and months. It's called proliferative phase, followed by spontaneous regression involuting phase. It is differentiated from congenital hemangioma, which present at birth. Case 10, 17 years old girl who presented with enlarging left breast lump. Ultrasound show an irregular hypoechoic mass with endoscenic margin and angular margin. Axial MAP image, MRI, show a large, irregular, homogeneously enhancing mass. It's called invasive duct carcinoma, which is extremely rare in the pediatric breast, account for less than 1% of all breast masses. Ultrasound appearance is variable and not specific. Like adult breast cancer commonly manifests sonographic as an irregular hypoechoic mass with suspicious margin, internal heterogeneity, antiparallel orientation, and variable posterior feature. However, invasive secretory carcinoma may appear as a small, less than 3 cm circumscribed hypoechoic mass. So any mass with suspicious feature or rapid enlargement should promote biopsy. Case 11 and the last, female patient, 15 years old, who presented she is known as primary rhabdomyosarcoma. Now present with an enlarging left breast lump. Ultrasound show an irregular hypoechoic mass with endoscenic margin. Axial PET-CT show a diffuse increased radiotracer uptake within the mass. Axial intravenous contrast MRI show a large irregular enhancing mass occupying most of the left breast. We are dealing with a metastasis. Metastatic disease is the most common cause of malignant breast mass in the pediatric patient. The most frequent primary malignancies that metastasize to the breast include rhabdomyosarcoma, non-Hodgkin lymphoma, and leukemia. So we can take home message. Breast masses are uncommon in the first 2 decades of life, and the spectrum of mass-forming lesion in the pediatric breast is different from adult. Most lesions in the children and the adolescent are benign and represent normal breast tissue or fibroadenomas. If imaging is necessary following a thorough clinical examination, ultrasound is the modality of choice to evaluate pediatric breast mass, giving it lack of ionizing radiation and high sensitivity in dense breast. Malignant breast masses are rare in the pediatric breast and are more likely due to metastasis than a primary breast cancer.